Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of
improve.
I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. And today I have with me Dr. Heather Young. She is a pediatric infectious disease specialist at UAMS and Arkansas Children's Hospital. Dr. Young, thank you for joining us.
Thank you for having me.
So we're talking about something that's not necessarily you would think of in the pediatric realm of things, syphilis, and how that's affecting the pediatric population right now. Are you seeing an increase in Arkansas?
Yes, we've been seeing it for the past, several years, since 2013 at least. And we've been seeing it in different populations. So we've been seeing it in our young sexually active population, but then we've also been seeing it because it can be passed from mother to child. We have actually been seeing a large increase of cases of congenital syphilis in infants.
And that's specifically in Arkansas? Are you seeing it where they're coming across state lines?
So it's happening nationwide, but the South and Arkansas in particular tends to be a hot spot. So we started out in 2017, there were 13 cases of congenital syphilis in Arkansas, and the health department has released that in 2022, there were 69 cases. And they're still counting the cases from 2023, but it's expected to have gone past that 69 mark from 2022. So we have been seeing it.
And you said in babies specifically, which is rare?
So it used to be rare. If you talk to a lot of people who trained, a few years before me, they never saw a case of congenital syphilis. It was something that was in the textbooks from way back when. But unfortunately, we've been seeing this surge, and as syphilis has been spreading throughout all of the adult population, it's been spreading in women who are pregnant, and by doing so and not getting appropriately screened and treated during pregnancy, they're passing it on to their children. And so we've even, sometimes those kids are caught in the newborn nursery and we're able to treat them preventatively then. We've had several cases of stillbirths. We have also had several cases of infants who have been born with a condition called hydrops from syphilis and have had to try to support them through that. But then we've also had cases that have come up later, about 6 weeks or later of age, and they come in with like the fulminant textbook presentation of congenital syphilis. And we even had one patient die here at Arkansas Children's back in 2022 from this.
And is there a pediatrician awareness of this happening?
I think it's growing. It's not quite at the level that we would like, but it has certainly been growing. I think a lot of the pediatricians who work in some of the high throughput nurseries are very, very aware. My colleagues at UAMS who attend the deliveries at UAMS are extremely aware. But if you're in a smaller town or at a smaller birthing center, it may not be something that you've come across yet, but it's coming if it's not already there.
And are moms not being tested and treated? What are you seeing?
So unfortunately, that's a lot of the case is, the recommendations used to be just you were tested at your first prenatal visit. Those recommendations have changed because a lot of women are contracting syphilis during their pregnancy. And so now the recommendations are to test at first prenatal visit, to test around 27 weeks gestations, and then to test again at delivery. Not everybody is following that. A lot of people are still following the initial just testing whenever they present for prenatal care. Our other problem is we have a lot of women who are not able to access prenatal care for whatever reason. And those mothers, we certainly need them to be tested and treated at delivery if that's the case.
So you mentioned prenatal care, and there is a lack of, there's maternal deserts across the state in a lot of ways. Are you seeing that play into this?
It has to be contributing. There's no way that it could be helping at all. So yes, we're seeing it in every single county. no matter where they are in the state. So no state. So if there's any barriers to prenatal care, it's hurting these women and their children.
So it's not just a centralized problem. It's all over. It affects all types, every corner of the state.
Yes. Yes.
And are these drug users? Are they people not wanting to be tested, or does that even play into this at all?
I mean, there's a small proportion who do use IV drugs or other drugs, but it's not everybody. There are plenty of mothers who don't have any perceived risk factors. About a third of all women who have syphilis don't have any perceived risk factors that you would note when doing a social history. Their only risk factor is that they have had sex.
So is there a specific list of questions, like asking the right questions that the physician should be asking, or is this something that women should be asking for additional testing for?
I would love it if women would ask for additional testing. Unfortunately, syphilis is very sneaky. So a woman can have sex, and then when she contracts syphilis, she may not see that original chancre. It may be present in the vagina where she absolutely cannot view it. So she can't give you a history necessarily of having had a chancre before. And because of that, it can go on. This organism is a very sneaky, stealthy organism that can evade the immune system and can hide out with long periods of latency. So a woman who has syphilis may have no idea that she has it. Therefore, I would, instead of just saying, oh, well, we'll only screen people who are at risk, at this day and age, at the rate that we are seeing here in Arkansas, every woman who is here in Arkansas who has had sex is at risk for having syphilis.
So social determinants of health play a role in this too, then?
Correct. I mean, so any barrier to prenatal care, any barrier to any care is going to increase the chance that a woman will go around with an untreated syphilis. There are definitely pockets of syphilis within areas, but it's kind of hard because the whole state is so saturated as well. So yes, every woman is at risk, but there's certainly some women who are far more at risk, and those women are disadvantaged for numerous reasons, and we ought to take extra steps to take care of them and their children.
So if the mom gets infected late in the pregnancy, does that make a difference?
That actually increases the risk of transmission to the baby. The later in pregnancy that a woman acquires syphilis, that the baby, when it's born, may not have the symptoms then, and you could have actually some false negative tests on the mom because you were testing too early before antibodies were able to be made. And so then those are the babies that often come back and are sick at 6 weeks of life with all the textbook scary signs that we all memorized for our boards.
And if it's missed, what happens to the child? What are you seeing?
So it can be very devastating. I mean, these children they can have profound anemias that, hemoglobin's as low as 4. So they'll have, they have periostitis. So their bones, it hurts the babies to move their arms or legs. They can have neurosyphilis, which can be devastating and can cause tons of lifelong problems, because when we do treat, we can't undo what damage has already been done. Our case of the patient who died, that child had congenital syphilis, and it affected her bone marrow so much that she was neutropenic, and then she got an overwhelming secondary infection. And that's what she ended up passing away from. But she was so systemically ill in general. So it can be life-threatening for these babies.
So early onset, and then there's also late onset for children too.
Correct. So we know from the pre-penicillin days that children who were born with congenital syphilis may not necessarily have had signs or symptoms early in life, but then later in life, usually around the time they hit puberty, they'll develop signs. So they'll get, there's they'll have problems with deafness that might not occur until they hit puberty. They might get an interstitial keratitis that can lead to blindness. There are lots of different deformities that can happen. So they'll have teeth abnormalities. They'll have bony abnormalities that can cause them they will look abnormal. And so given all of that, this is not something you should be like, oh, this baby looks fine now. Now they do, but if you don't take action and investigate fully now, you could set them up for disaster later on in life.
So what's important for pediatricians to know? What do you want them to know especially within that 10-year window that can be detrimental?
Well, I would say for anybody who's seeing a baby who has just been born, there needs to be syphilis testing on the mom and syphilis testing on the baby. Especially if the mother has had all of her syphilis testing throughout her pregnancy and everything is negative, you don't need to worry about the baby as much. But if there's any question, if there's any gaps, I would get syphilis testing on the mom and also on the baby as well before they leave the hospital, before they leave the nursery. And if you're in the outpatient setting and there's a baby who comes to you for their newborn child check and you don't have records of any of this, I would go ahead and check an RPR is the test of choice, or a VDRL, whatever is available at your lab on that baby, if you don't have any records at all. You should also have a low threshold to call the health department to ask for assistance, because they can often find records that you may not be able to reach.
What should mothers be aware of?
Mothers should advocate for testing for themselves. They should ensure that they receive the testing that is the standard that is set by the CDC, regardless of what their personal lifestyle is. It should just be something that is just done, and they should do their best to ensure that hold their delivery providers accountable and say, please test me.
And penicillin and amoxicillin, those are getting harder to get, right? Is that harder to find?
Well, so penicillin is the only treatment available for pregnant women and babies. And we did have a bicillin shortage. Bicillin is the treatment of choice for pregnant women. And bicillin is sometimes used in the infant. We also use IV penicillin. If you truly have congenital syphilis, you're getting 10 days of IV penicillin instead of just the bicillin injection. Thankfully, it seems like the bicillin shortage is getting better, but it may be something that we have to be concerned about in the future. So if there's ever any question about which medicine to give or how much medicine to give, or does this child truly need it, I'll say that the individuals at the health department, and then also from the pediatric infectious disease standpoint, we are always available. We are on call 24/7, and we are very happy to help walk any provider through the algorithms that are there to decide whether or not a child needs treatment and how to determine which best treatment. We're always happy to help. We know that algorithm is very confusing, and we're happy to work with you through it.
Well, Dr. Young, those are all the questions I have for you today, and I appreciate the time that you've taken to explain and go through the steps of what the healthcare community needs to know, and thank you for all that you do.
Thank you.
And that's it for AFMC TV. Have a great day, and thanks for watching.